is Dr. Farhana Sarkar. On behalf of my team, I am presenting our paper Smart Sushastha Kormi, a digital healthcare model transforming primary healthcare delivery in Bangladesh. As like other LMICs, we in Bangladesh also facing lots of problems in our healthcare system, including there are only 1.1 physicians per 10,000 population in Bangladesh, which leading vast population underserved, and also high financial burden. Is about 74% of healthcare costs from out of pocket expenditure, which leading or pushing millions to poverty and growing number of NCDs in our population. So we need accessible, scalable, and affordable health care solution for improving healthcare access in underserved population in Bangladesh. So what is the motivation behind our study? Is bringing the healthcare to the community to improve the healthcare need in Bangladesh. And our objectives of this study is to develop and evaluate the SSK model, a new pharmacy-led digital healthcare system to enhance access and early detection of NCD screening directly to a local community level. And the last one is to improve care coordination by creating a seamless referral systems connecting patients, pharmacies, and doctors. So this is our SSK model. In the left side, you can see that pharmacy, and there is a pharmacy worker who work in the pharmacy. So you want to actually equip this health worker with our digital POCD devices, which is connected with a mobile application. So through the mobile application and with the smart devices, he or she will provide the services to the community level people who comes to the pharmacy. Actually, in Bangladesh, people comes to the pharmacy to take medicine. Even they take antibiotic without any prescription. So what we want to do that they actually provide the informal caregiver or informal health care providing. So we want to actually convert them to the formal healthcare center or formal healthcare provider through our SSK model. So they can screening the health risk, and if needed, they can provide the health education, and also if based on the outcome of the health assessment, they can refer to the next level of health need. They can connect the patient to the telemedicine service, or they can refer to a GP center for the face-to-face doctor consultation, or for the next level of service they can do. So we equipped our health kit with weight scale, height scale, oximeter, glucometer, and blood pressure, and also the ECG. So in our study, we deployed our system in 479 pharmacies across different rural areas in Bangladesh for 1 year for this study, and a total of 8,550 individuals were enrolled in our platform, and we collected socio-demographic and clinical data through our system for 1 year, and then we analyzes descriptive analysis and inferential statistics were used to evaluate our NCD prevalence. So we can see our participant demographic statistics that mainly male participants came in the pharmacy, as in Bangladesh, as per our socio-demographic context. Our female do not go to the actually in any shop, especially in the rural area of Bangladesh. So we can see that in our study we got 63.6% of male participants and between the age of 18 to 39. So we got results. We can see that there are more, the SSK model identified hypertension and diabetes as the most common in cities in Bangladesh. Is about hypertension is about 11.3% and diabetes we got 8.5% among the population, study population. And also prevalence of hypertension by age group, we can see that there is a clear peak between the age group of 50 to 59 years old, and which is 3.23%. So we can see that through our system, over 12,000 vital signs were recorded, demonstrating high engagement across pharmacies, and also 4,542 digital prescription was generated, showing an active telemedicine loop, and also 8,515 AI-based risk assessment performed, flagging the potential health risk. So we can, this result actually leading to tell us that the SSK model is a fully functional digital healthcare ecosystem for our countries. So we can conclude that SSK model empowers local pharmacies. It successfully integrates pharmacies into the formal healthcare system, turning them into critical access points. Technology-enabled equity, the use of digital tools, AI telemedicine improves early detection and reduces barrier to care, and also an effective model, that is the SSK model is a viable and scalable approach for delivering primary care in a resource-limited settings. So in future, we can actually conduct more researches on focusing on increasing female and cross-age participation to create a balanced, nationally representative dataset for more inclusive research, move beyond risk assessment to develop a sophisticated AI model that can predict future health risks, enabling truly preventive care, integrate a long-term monitoring system for NCD patients. Thank you.
Thank you very much. I have a quick question from you. What's the duration of the study and the cost involved with the participation of for the screening purpose for the participant?
Yeah, duration was 1 year.
Is there any cost involved to the participant?
No, there is no cost for the participant. But actually we want to thank our partner, Cement Health Limited. They actually help us in operation the whole things.
The cost is $1.
Yeah. Thank you. So, floor is open for questions. There are so many health informatics sources, so it's open for questions.
You are going to roll out it as a screening method, or it is going to be rolled out as a screening method, screening program for people?
It was a screening method as well as risk prediction and telemedicine, and overall the referral system also included in this system. Yeah. Actually, our target was to make the pharmacies in Bangladesh, those actually serve as an informal health care provider, because any person who can take antibiotic without any prescription, which is actually not good for health or may get the risk. So what we converted to this model, that every pharmacist can become a formal healthcare provider, and so that every person who actually visit pharmacy, they can have their own health account, which can be connected throughout the society or through the country. So what he got from the pharmacy, who I got, and it also includes all the health records for the specific person.
Please go.
Thank you for that interesting presentation. One thing that was highlighted in the presentation was that a stark disparity in gender participation. I'm very much interested in that, and wondering how you can improve the female participation.
Yeah,
What are your plans?
Thank you so much for your question, and this is interesting. Yes, in Bangladesh, actually, the social context doesn't allow that female, especially in rural area in Bangladesh, female do not go to the shop or outside home very much. So that's why we can see that the effect here. They do not actually go to the pharmacy to take the medicine. Mainly, male go to the pharmacy and take the anything for the female. So actually. In our another study, what we have done, this SSK model, we equipped with health worker who goes to the door-to-door service. Because in rural area, actually people allow that they come to the doorstep and take the service. But in the urban, we do not allow. So our SSK, with this equipment, go to the door-to-door service. So that showed in on another study here. So this
you
is
hope
another
to
way
sort
to include actually women. Yeah, thank you.
Thank you.
Yeah, thank you. So actually next presentation is also from Moman. So the title is Development, he's good, sorry. Okay. Development and validation of an AI integrated screening tool for early detection of women at high risk of endometriosis in Bangladesh. The paper is by Johan I, Chaudhry S, Chaudhry S.B, Abbasi S, Zaman M and Mamun K.A.
Thank you. Thank you so much, and thank you the session chairs and audience. And how many of you actually don't hear about the endometriosis? Can you raise your hand? Endometriosis. Everyone knows about the endometriosis, right? Okay. So endometriosis is one of the leading women health issues in all over the world. So today I would like to share with you that development and validation of an artificial intelligence integrated screening tool for early identification of women at high risk of endometriosis in Bangladesh. It's a collaborative work between the Endometriosis and Adenomyosis Society of Bangladesh and United University and CIMED Health. So let me share the situation. One in 10 women in the reproductive age affected by the endometriosis, and diagnostic delay due to lack of awareness, social stigma, and access can be 6 to 10 years. And the life of the endometriosis patient is really, really unthinkable. Who suffered that, they knows. Even you are a physician, if you had the endometriosis, you can think of what is the situation you had. And maybe you had an operation, you need multiple operations. So, and that consequences infertility, mental health, and strained relationship. So to address this situation, how can we do the diagnostic, reduce the diagnostic delay? And this is one of the biggest challenge we took. And how can artificial intelligence can be harnessed to identify the early risk factors from the adolescent age to all ages for that. So, and we actually try to do it, okay, how can I reach to the very rural deep areas, the people who don't have the education or access. So we made it two options. One is, I'm educated, I can use my own smartphone to do the screening of endometriosis at my age of adolescent age or next. And also health worker is a very proven model in developing countries. How can health worker in a tab and take AI tool in there and give a door-to-step screening to the individuals. And in that way, our system should be culturally adapted and also able to identify the early risk factors with the clinical validations and timely referrals to reduce the burden of the disease. So we actually follow the 8 steps. What we did, what is available around the world and what is the literature saying about the endometriosis screening and how it should be non-invasive, because we want to identify the risk at the doorsteps, not come to the clinic and do the ultrasound or other things. And we actually made an in-depth interview with the gynecologist who actually look at the patient and also the patient. And we interviewed more than 100 endometriosis patients about their journey, their symptoms, their sufferings, and designed the AI model and made a clinical workshop, consultative workshop to actually take the knowledge of AI expert and gynecologist and the patient. And you know, in UK now new systems like PPIE, so we need to engage the patient and the providers. And then we made into a digital integration to the mobile phone and did a pre-test and did the clinical validation. And we have an inclusion and exclusion criteria. And for the clinical validation, we did a cross-section study and selected 2 hospitals and the solutions. And you can see here our solution. When we did that, we did a clinical approval from the Bangladesh Medical Research Council, and we follow the whole process. You can see the version 1 and the feedback of the consultative workshop version 2 and the pre-test version 3, and we actually are now doing a clinical trial. So as we said, that community health worker and self-one go to the doorsteps and using only 5 minutes or less than 5 minutes to actually take the risk factors and also the histories and integrate it to a systems, and then it identify the high risk or no risk. And in that way, high risk go to the hospitals for the further diagnosis and confirmation, and if it is diagnosis, yes, so that we can follow up through the systems. And you will be happy to know that based on our preliminary study of more than 300 patients, and compared with the app and the gynecologist, that the gold standard method, we got more than 83% accuracy and with a more than 80% sensitivity and specificity, with a more than 80% precision and F1 scores. And what we found that we are actually adding more more patient. We have a target to go at least 1,000 patients to do the clinical trial completions. And what we found that among the high risk patient, 75% actually reported that dysmenorrhea, and dysmenorrhea is one of the leading cause of the endometriosis. And among them, we also found that who are at high risk, they have a depression and others common symptom that we see in the endometriosis. And among the participants, 206 women are married, and among them we got a dysmenorrhea and other infertility reported issues. So I just want to show you that how this simple systems works. So it is in 20 seconds you can see that how we can do the whole screening of the systems and identify the high risk patient and refer to them for the gynecologist to actually do the confirmations. And this is a collaborative effort of gynecologist and AI scientists together in Bangladesh. So you can see within a few steps you can get the risk factors. So what we actually we are in the process of finalizing our clinical trial and actually rolling out in Bangladesh, and which will democratize the endometriosis care, reducing the diagnostic delay and improve the quality of life of the who are risk of endometriosis, and especially infertility issues, because if we can early intervention, we can reduce the infertility issue, and it will reduce the economic burden. And we are in the process to how can we scale these things in different culture and different context. And I would like to thank you all our partners, and thank you so much for Global Public Health Summit for accepting our paper, and happy to actually collaborate and actually impacting millions to millions women in the world. Thank you.
Thank you very much for your very interesting presentation. Now floor is open for questions. Yes.
Thank you for your interesting presentation. So when scaling of this intervention, the computer literacy of the women will be an issue, isn't it?
Sorry?
The computer literacy of the women to who you
Okay.
administer this. So how are you going to address that issue?
Not really. So we actually, myself and with team, we are working 10 years with the rural, urban, and the workplace settings. So what we realized that we always say that computer literacy or technology literacy is not there, that's why people will not be able to use the technology. But it's proven wrong, because we have two options. If I'm educated, I have the smartphone, I can use my self-care. If I don't have the smartphone or computer literacy, we have a health worker. We train the health worker, and we know a health worker not able to do everything. So what I designed it, health worker is a facilitator. And the brain of the health worker is here, artificial intelligence copilot. And that copilot have all the modules of screening diabetes, hypertension, endometriosis, breast cancer, and so on. So that health worker is going to the door to door. And what we always see that we train the health workers, and with a 1 or 2 tasks, go to the doorsteps. And creating disparity and leaving other people in the household, like health worker go to the household, giving a maternal health. And she is actually living behind the older lady in the household or any service. So how can we transform the community health worker to be a empowered healthcare provider using AI copilot and point of care diagnostic that Dr. Farna showed it previously, that she can actually create a health account for every member of the household from 2 years to older people, and immediately when registered, system automatically tells her what health screening, education, risk assessment, give it to that particular person of the family, and based on that she can know how to provide and what to provide, and in that way all the risk assessment and advice comes to here, and she may act as a facilitator. So that digital literacy is not a barrier, it's an opportunity to actually reach out to everyone so that we can create an equitable healthcare for all.
Okay, thank you. Any other
Thank you.
questions?
I hope it answered your questions.
Thank you.
So this was, maybe pardon me for my ignorance, so this was answered by the, not the healthcare workers, but individual participants, right?
So what happened that this one have a integrated app, it's called Shushasta, means good health. Shushasta have a multiple screening tool integrated to
In
one
one.
solutions
Okay.
as a module. So when health worker going to the household, if 2 years baby is registered here, and system automatically tells what is the growth checkup of 2 years baby needed.
So for the whole family
Yeah.
is registered.
So the whole system is AI driven and clinically validated, so that health worker no need to be very expert on that. Expertise is here and getting all the advice, and she is facilitating, so that everyone in the household getting the health care. And endometriosis is part of this
Yeah.
whole system.
So the health workers have smartphones, everyone.
Yeah, health workers could have a smartphone or tab.
Tab.
Now it doesn't matter, because nowadays I think almost everywhere health worker has a tab for manual data entry. So we want to transform it to AI based solution, and manual data entry have a lot of error. So like an Apple Watch, we call it IoT, that the device Dr. Farna showed, all the integrated device, take all the vitals and comes to here automatically, and AI actually giving the answer, is your blood pressure is right, it's high, or you have any risk based on your symptoms.
Okay, thank you. That's
Thank you.
helpful. Any other questions?
Right.
Thank you.
Thank you very much. Now we'll move to the final presentation, oral presentation, digital health